We'll discuss some figures about the epidemiology of the SARS-CoV-2, the new coronavirus from the one member of the coronavirus family of nidovirales order. As you know, until December last year, there are only 6 coronaviruses were known to humans. Most of them, except 2 of them, they were causing cold, mild symptoms, except the 2 outbreaks that happened around 10 years ago, 8 years ago, the MERS and SARS. Initially, they called the virus, the SARS-CoV-2, causing COVID-19 as the novel one, until the International Committee of Taxonomy of Viruses renamed it as SARS-CoV-2. Updated this number yesterday just to show you. I'm really when we look at the numbers that we'll see in a figure, that we look at the number of cases here. We always look at the number of cases per country, but I look at things in a different way, and we'll discuss that in a minute. We look at the US are leading the numbers, then India, Brazil. This is in terms of actual number of cases, and the media attention is mainly going for number of cases. But I think we need to look at something different. If we look at in terms of the number of cases in Jordan, we are ranked 136 with 2,411 cases until yesterday. If we look at the number of cases per million subjects, for example, in Qatar, their population maybe around 2 million, they have 42,944 cases per million. And I think this is the most important thing that we need to show in the media, globally, actually, not just at the, we need to look at the distribution of the disease per country. It's not important for me to know that we have 2,400 cases in Jordan. I need to know the number of cases per million and to compare to the other countries. If you look at Qatar, in number of cases, 42,000, maybe they rank 20 or 30 or 40. But if you look at the distribution per 10,000 or per million, you'll see that Qatar, Bahrain, then other countries in Africa are leading the world. And the US, in terms of numbers, it was leading the world. But in terms of the cases per million, they rank 10. You can see like Oman, Qatar, Bahrain, they are within from our region, within the highest number per million. In epidemiology, we look at the rates, not the actual numbers. So we need to think that we believe that Qatar, Bahrain, Oman, other countries here, Kuwait, in the region, much work should be done for them because the number of cases per million is high. So Oman, Bahrain, Qatar, Kuwait, then USA, Brazil, we look at the numbers of per million, and this is high. In Jordan, if you look at the number of cases per million, we rank 177. So the situation in Jordan, in terms of cases per million, is good. If you look at number of deaths per million, you see that countries like San Marino, small country, and then Peru, Belgium, Andorra, Spain, UK, Chile, and thanks God, none of countries in our region are within the highest number of mortality per million. So I encourage that we need to work on the showing the numbers per million or per 100,000 as that we do, rather than the actual number of cases. In terms of number of deaths per million in Jordan, our situation is good. We rank 178. Are we doing well in Jordan until date? Yes, in terms of the number of cases per million and number of deaths or severe cases per million. What could be done next? This is what we hope we are going to discuss over these 2 days. The screen versus diagnostic tests. I personally believe that it's scientific opinion that we need to consider the the antibody testing, especially now at the start of this pandemic. We were looking at the PCR because there was no antibody testing were developed, but then some low quality tests were developed, but now we have highly sensitive antibody tests that could be done. It will be cheaper, more sensitive than the PCR, especially the PCR used in is the nasopharyngeal with sensitivity of 50 to 70%. Treatment choice, actually, the number of cases are increasing. We need to be prepared. We look at the evidence from clinical trials, we can see that remdesivir currently is the most effective treatment compared to other treatments actually for the treatment of COVID-19. So we need to consider it for at least for moderate cases or severe cases. because it's going to shorten the duration of hospitalization and will have better outcomes compared with other medications. So I would encourage countries in the region also to be prepared for getting this medication. Vaccines, we'll discuss later in one of the slides, the vaccines, the pipeline, but still we have to see good that our region now are including some clinical trials for vaccines. We need to see the impacts of these vaccines in terms of efficacy and safety. ICU beds, we thank governments in the region that they invested good time to have a good number of ICU beds in different hospitals. And so we are now better prepared than the start of this pandemic. Compliance with safety measures, this is one of the major issues, especially in the Middle East, because our communities are different from our Western countries. This is, personally, I encourage, most colleagues maybe are asking for opening things, but for me, I think we need to consider our community, the compliance with safety measures before we open things widely. And the laws enforcement, and we thank governments who are working on this direction, but I believe that the community should be playing a major role in terms of the compliance with these safety measures. I just want to refresh our minds about how things started, how things developed, and how we act. For example, we expect maybe next season, or we might have another pandemic from flu, from other COVID-19, from other things, how we can learn lessons from this pandemic. We look at the distribution. Things started from other regions, even outside our region. We started with number of cases, then the number of cases increased over the weeks until the pandemic announced on 10th of March. So you can see the Eastern Mediterranean, we started by the week 5. So how we could act it better, or how we can act in the future in a better way when we hear about such pandemic or such epidemic in different countries. If we look at the travel history, in West Pacific area, most people travel to China. Then we look at our region, like Eastern Mediterranean country, people travel to Italy or to Iran, and the number of cases initially that were from these countries mainly. And we have a small proportion of unreported travel history. I personally believe that initially in this pandemic, we were looking for the temperature of different airports. I traveled actually to Lebanon, traveled to Saudi in early March, late February, and the screening test was the temperature recording. I believe that in the future, we should be recording the travel history and to endorse travel restrictions. When Italy was closed, many travelers traveled to the UK, then they come back to Jordan. And we were not reporting that they were initially in Italy. So I think we need to consider a document where people can sign about travel history in case of future pandemics, because this is very important. And for me, I believe it would be worthwhile. We'll discuss later on the symptoms like fever is present only 50% of the subjects. So I think in such pandemic in the future, we have to have travel document restrictions, and we have to have a travel history card that would be more worthwhile. In some countries, the Gulf region, people travel from Iran to Bahrain, then to other Gulf countries, and they were missing and they spread the disease in a big way in these countries. So we can look at, in the Eastern Mediterranean region, we started in week 9, actually, this pandemic in a good way, then the week 10. I believe that if actions were done early, especially in the travel restrictions, we would have saved the region from many cases. They check about the method of transmission, and you can see here that some will not reach 100%, more than 100%, because some subjects were reporting transmission through the household or occupational, but you can see the household contact, travel, occupational contributed, and there is also some transmission through healthcare professionals. We'll discuss these more details throughout these 2 days about the symptoms. We know, most of us know that the point of entry is eyes, nose, and mouth. And if you compare SARS-CoV-1, the leading to MERS and SARS, and with SARS-CoV-2, we can see that especially in cardboard, the virus can stay up to 48 hours. So we can see this virus is the main difference with it. Compared with the MERS or SARS, the mortality rate is much lower than these viruses, but the actually staying, the transmission and staying services for longer duration. We're expecting that the virus will be weaker over summer. This did not happen, although actually exposure to sunlight would reduce the effectivity of the virus. So we need to consider the infectivity during the incubation period, also during the symptoms, especially in the first 9 days. And incubation period, there's debates on this one. We keep changing out this one, but the main, actually, the 97.5%, the incompetence interval is between 2 to 14 days. There'll be outliers around 20, 21 days. Most cases will be, the incubation period is from 2 to 14 days with a mean of 6.4 days. So we should not count on symptoms like the temperature recording, because symptoms appear from 2 to 14 days after exposure of the virus. And you can see there is different symptoms. And when we'll discuss later today about the flu virus symptoms, you see different symptoms, except they'll be in common between these two viruses. So we thank governments who invested in preparation for the flu vaccine to reduce the chaos or the load on the healthcare services. So these are symptom distribution like headache, loss, smell, nasal obstruction, anesthesia, weakness, cough, malaria, and rhinorrhea, and taste dysfunction. And you can see distribution by age and gender, 6. The National Institute of Health guidelines for COVID-19 severity spectrum is mainly counting on the oxygen saturation. One case they have pneumonia without saturation rate is than 94%, they consider it like as severe illness. So I think we need to prepare for the management of symptomatic, mild, moderate, and severe cases, and what we can be done. And also we need to check the updates and the management for these different categories. The predictors of mortality among COVID-19 hospitalized patients in the UK, the age was actually the main predicting factor in addition to the lymphocytopenia. So we need to check to screen subjects for the lymphocytopenia and also for elder age, and to try to reduce the number of cases, at least among elderly, to reduce the mortality rate. Vaccines in the pipeline, you can see that preclinical studies around more 140, then phase 1 we have 19, 12 past phase 1 now, they are phase 2, we have 5 phase 3 trials, and the one in Russia, I'm aware, we haven't seen even still the publication from that one, but it's approved for limited use in Russia. But we have 5 vaccines. The AstraZeneca and Oxford, University of Oxford actually announced yesterday the stoppage of the phase 3 clinical trial, although they were promising that they will get the vaccine in September because of the ADR. As you know, the phases in phase 2, we test the vaccine for the trying to look at the best dose for the vaccine, while in phase 3, we give it for a large number of subjects, and we can see that the efficacy ADR at a large scale. So this is why it's very important that these vaccines should be reviewed carefully. And I always encourage actually to look at the strains in the region and the spike protein to see if there are differences to assess the vaccine's impact. Thank you very much.